Greetings from India. Namaste. This is Dr. Professor Vineeta Gupta, heading the Department of Periodontics, Government Dental College, Raipur. Today's topic is Stent as an accessory tool in periodontal measurements. I dedicate my presentation to my teacher, Dr. KL Vandana ma'am. She is a senior professor in CODS Davangere. My college, my team, periodontal probing. For decades, probing clinical pocket depth and attachment level have been recognized as dentists the most important tool in diagnosing periodontal health and disease. There are various physical methods to measure the distance from the bottom of the pocket to a fixed reference line, usually the gingival margin or the cemento-enamel junction. But still, probing accuracy and precision can be questioned as they are affected by probe position, pocket depth, inflammation, and enlargement. A better reflection of periodontal destruction can be obtained by the measurement of clinical attachment level, that is CAL, and a wonderful paper written by Dr. Vandana KL, must read. The major problems in location of CEJ are difficulty in probing due to its subgingival location. The examiner totally has to rely on its tactile sensitivity, lack of distinct demarcation felt during probing, and the vertical course that the CEJ takes on the proximal surfaces. And despite all these problems, in CEJ identification, CAL measurements are a part of Community Periodontal Index still. Stents is only recommended during clinical trials, which will minimize the errors in terms of over and underestimation of CAL. This is the stent that we'll be talking about. It's the occlusal stent, or you can also call it as a vertical stent. It is a customized accessory measurement tool which is widely used in recording clinical periodontal parameters. It minimizes the error and it also minimizes the over and the underestimation of measurements during the clinical trials. Stent facilitates the measurement recording, which is easily reproducible and dependable. It gives us a fixed reference point, and whatever the measurements we are taking, we refer it as relative attachment level. The different types of stents, the broader classification is the intraoral stent and the extraoral stents. The intraoral stents can further be divided as non-surgical and surgical stents. A few to see are the occlusal stents, periodontal stents, and the pedo stents. Clinical application of stent in periodontics. The clinical application basically is to minimize the error, and the use of customized stent provides an alternative which is referred to as fixed reference point, and the other measurements that are there gives us the relative attachment level. One of the stents that we will be studying is the vertical occlusal stent that we've already seen, and the clinical attachment lodge, which occurs in the vertical direction from CEJ to the base of the bone defect, is measured as probing attachment level, that is PAL, or clinical attachment level, that is CAL. It is also referred to as occlusion stent because of its location on the occlusal surface of the teeth, if you are able to appreciate it on the diagram. The picture, the probing location is apparently less variable and more reliable, increasing the intra and inter-examiner reliability and helps to maintain a dependable fixed reference point. Furcation involvement is a common sequelae of periodontal disease. For its effective management, we have to have a reliable diagnostic tool that can accurately measure and quantify the furcation defect. There have been some realities and limitations about the measurements of the furcation. Here are few pictures showing the endodontic stopper, the probes adapted to measure the furcation area, the neighbor's probe that has 3 mm marking. So again the data has to be approximated. And use of the furcation stent may act as a new frontier in the field of furcation diagnosis and measurement. Especially for the horizontal CAL, that is the term used for the horizontal measurement of a furcation involvement using a fixed reference point with the help of a furcation stent, and to record more precise and reliable measurement of the horizontal component of the furcation free from detection, it is very stable and minimizes the reproducibility errors. The next stent that we'll be talking about is the stent for interdental papillary deficiency. This is same like the vertical stent, but here the groovings that are there, the shallow groovings have been here the acrylics has been minimized totally, and the probe directly falls on the papilla. The stent used for vertical probing has been modified here, and for papilla we can measure the location of the papilla. Fabrication fabrication of stent is very simple. It is done either by cold or heat cure acrylic or a thermoplastic material with a uniform thickness that is maintained by use of thermoplastic material that is of 2 mm, and it provides basically the behind this is the finish, and we get a neat finishing. This is how it is prepared. We can do it manually by heat cure or a cold cure, or a thermoplastic compression is used and the stent is obtained. The extent of the margin differs in different kind of stents. Here when we are targeting the papillae, we are extending the stent a little beyond the 1/3, and when we have to see the marginal, we are concerned with the marginal gingiva, we extend it to the 1/3 of the on the facial or the buccal surfaces. Talking about the vertical occlusion stent first. Here the thickness of the stent, as I have stated, it is usually 2 to 3 mm, and the occlusal surface bulk contributes to its strength. The material is acrylic or a thermoplastic sheet, and the grooves are made for the stent for the probe. Here the grooves are made for the stent for probe placement, and it should be adequate to place the probe, not too deep or narrow, and the vertical grooves were made to guide the probe penetration vertically in the same plane every time when the measurement is taken. The apical limit of the vertical groove was used as the fixed reference point for the vertical probing depth, and this stent is used for gingival margin position measurement and before and after, and at the mid buccal site interdentally before and after the treatment. This is the interdental papillary measurement. Here we have modified it. On the labial surface, thickness was 2 to 3 mm, whereas on the lingual surface, stent should be thick enough comparatively to the labial surface in order to provide strength and retention. Instead of shallow grooves in the interdental area of the stent, it was completely trimmed off to the incisal edge from the labial side in order to place the probe parallel to the tooth surface to measure the tip of the papilla from the reference point. And the complete trimming of the stent in interdental area prevented the tilting of the probe while measuring the distance from the fixed reference point of the stent to the papillary tip. And the apical limit of the stent acts as a fixed reference point. The apical margin of the stent was highlighted with a black marker to clearly distinguish and ease the probe marking readings at that level. The furcation stent, its material and is all the same, but the extension it is beyond the attached gingiva, and area on the lingual and the buccals aspect of the furcation involved side, and the thickness is as usual, it is 2 to 3 mm, and the hole is made on the approximately at the entrance of the furcation to guide the probe insertion horizontally in the same plane every time when the probe is we are taking the measurement, and the outer surface of the hole acts as a fixed reference point for the horizontal probing depth. Limitations are that it's still cumbersome and unrealistic during the service, and it provides valuable measurements for only a few number of patients. Its use for longer duration, that is 1 to 2 years of clinical trial, is still questionable. Storage, it can be stored in in the cast itself, and for the entire duration of the study to minimize distortion, or it can be stored in normal saline with patient coding on the bottle or the box. The advantages are the it helps in localizing the exact site of measurement to ensure that the same site is being measured at each visit. It acts as a fixed reference point, and the fixed reference point is easily visible and accessible. The measurement recorded are reliable and reproducible. This minimizes the error while hidden CEJ is used as a reference point. To conclude my presentation, the use of stent for vertical probing solved many critical issues in CAL measurements and gingival margin position for gingival recession assessment. The clinicians have to utilize the availability of these stents regularly to enjoy the reliability and reproducibility of periodontal measurement data recording during the clinical trials. My acknowledgement to Dr. Vandana KL and Dr. Shivani. Here are the references. Thank you all for patient hearing.